Can you hear me and see the screen okay?
We are all set. Good to go.
Oh, great. Thank you. So, and you recording? Great. Thank you. Thanks everybody for coming to the Lunch and Learn for September. It's good to see you all. And we'll go ahead and get started. We want to talk today about the updated standards. So standards 2025, which we will have to follow starting in the new year. Just as a friendly reminder who we are, so pictured here at our golf tournament from last Friday, we have Heather, who is our Director of Experiential Education, myself in the middle, Chantel in the blue jacket all the way on the right-hand side, who does our Experiential Learning Distance Pathway Coordinator, and Dom up in the top, who is very busy out on the course taking pictures of everybody. So we are all available anytime you need us. Please reach out. We'd love to talk to you and hear what's going on. I know the good, the bad, the ugly, but we do enjoy connecting with everybody because we are not always at this site. So please reach out if you have any questions, and we're happy to speak with you at any time. So for today, the Accreditation Council for Pharmacy Education, this is ACPE. And they are in charge of, they're our national agency for the accreditation of professional degree programs in pharmacy. They also provide continuing pharmacy education, as you probably are very familiar with, but they are our governing body. So it's when they come to visit and accredit the schools, it's sort of like a JACO visit or the Board of Pharmacy walking in. It's a stressful time that you've been preparing for and writing reports for a very long time, and then it's upon you, the site visit. So we've done well, but it is a stressful event when they come. So the mission of ACPE is to assure and advance the quality in pharmacy education. So they are recognized by the United States Department of Education as an accrediting body, and so they have to meet certain things for the USDE also in order to be an accrediting body. So they have taken the 25 standards that they have had previously and condensed that and simplified and clarified into 7 standards. So with this simplification, they used to have a guidance document that was separate, and they have also condensed that into this one document here. So we are all becoming familiar with what is in this document. And for today, we're going to talk about standard 3, so experiential learning. But in this document is everything that we should know and need to have a successful program and turn out. And the goal is to turn out practitioners. They are, as they start their APPEs, they're APPE ready. And then as they start in their profession, they are able to provide patient care in a variety of healthcare settings. And so they are practice ready. And also they're able to contribute as a member of an interprofessional collaborative patient care team. And so they're being hopefully groomed to be team ready. So all of these things make up what's behind the standards here. So again, there are 7 standards. We're making practitioners who are practice ready and team ready. So standard 3 deals all with experiential learning, and then it's broken down. So 3.1 deals with IPPE. And I pulled out just a few things, some that have changed or been updated or clarified with this most current rendition we're going to work with. So the IPPE is composed of at least 300 hours. And in that, it's broken down that there have to be 75 minimum in a health system, and then 75 in a community setting. And the other 150 hours can be in a variety of patient care settings. So typically at Western New England, we have 112 or about 112 in community, about 112 in a health system. And then that third block they go on can be any combination, or sometimes a specialty or compounding, or an AM care if they've had a lot of experience setting. And so those are some of the ways that it breaks down, but each institution does it a little bit differently. For our distance learning program, we're proposing 2 IPPEs in which the students will have that split right in half. They'll only do 2 IPPEs, so they'll get half in a health system and half in a community. So we do try to change and adapt to what's going on and what can be the most efficient and best way for a student to learn and have these experiences, and also for our preceptors to create these experiences that'll hopefully fit in to a workday. What's new, there's no simulation counting towards these 300 hours. So there used to be some hours that could be dedicated. There used to be some service learning, some different parts. But for now, they're saying no simulation at all will count towards 300 hours. They said it does provide value, but that they will not okay it as counting towards the ACPE experience. And then our next standard, 3.2, deals with ACPE expectations and ACPEs. And so with this update, or actually this part, the A part did not change, but ACPEs emphasize continuity of care, and they incorporate all the acute, chronic, and wellness promoting patient care services in outpatient settings, so community and AM care, and in inpatient settings like your health system and your hospital. In the aggregate, the ACPEs expose students to diverse populations, including age, gender, neurodivergent race, ethnicity, and socioeconomic factors, as well as disease states. And I just put that in italics to emphasize why we do field encounters. So as you know, students behind the scene are doing field encounters, and they are putting in de-identified patient encounters and checking off which interprofessional healthcare practitioners they've been working with. So again, in the aggregate, we can prove to our accrediting body that students are getting this diverse experience throughout school. So even if one site doesn't check all the boxes, overall, they're collectively getting that. And 3.2b deals with ACPE duration. So the curriculum includes no less than 36 weeks, which is 1,440 hours of ACPEs. And each of those is at a minimum 160 hours. So some schools will have 4-week rotations. Our school at Western New England, we have 6-week rotations, which allows for that 1,440 hours. The majority of the ACPE curriculum is focused on patient care now. So that is a new addition to this standard, in which they say almost all of your hours need to be patient care. So sometimes that patient care isn't necessarily patient facing, where you're directly involved with patient care, but it is patient care overall. So whether it's managed care in a pharmacy benefit manager or working on a leadership team, it's all focused on patient care. And 3.2c talks about timing. So we know the ACPEs follow the successful completion of all IPE and all parts of the didactic curriculum before they can go on ACPE rotations. What is new and different, they're clarifying that required capstone courses or activities that provide opportunity for additional professional growth and insight, they are allowed during or after completion of ACPEs, but these activities do not compromise the quality of or decrease the time spent on the ACPEs. So they do not count toward the required 1,440 ACPE hours. So at some points, we have had students come back for mock NAPLEX or had a professional development day built in, because it is towards their growth and their professional development. However, the ACPE is not allowing that anymore. So we'll be giving mock NAPLEX again on Saturdays. But those professional developments, while they were encouraged and they are fine with that, they don't want it to count towards those 1,440 ACPE hours where students are giving hopefully patient care. For 3.2d, required ACPEs, so we all know that the 4 required ones are community, AM care, hospital or health system, and inpatient adult patient care, which can be called acute care, gen med. Those are the required ones. They must take place in the United States or territory or possession. The majority must involve interprofessional communication and collaboration. So again, overall, that big picture of their last year and their progress, overall, they're working interprofessionally and collaboratively. What's new is bolded here. The non-traditional doctor of pharmacy pathways need to demonstrate all students have completed or met those 4 required APPEs using a formalized faculty assessment. We need to document the achievement of these outcomes. So they must have the same education that an in-person or traditional student has. So all aspects of any program offering this non-traditional doctor of pharmacy, it's assessed in the self-study process, which is part of ACPE's, what we meet for ACPE, and then it's reviewed on site by the evaluation team. So we need to be showing that we have the same criteria and the same outcomes for our non-traditional students. So for us, that happens to be our distance learning pathway. And 3.2E, elective APPEs. So they're structured to give students, they're able to mature professionally. They are able to have a deep array of experiences, and then they can explore various parts of practice, so various sectors of our profession. What's different here, of the 1440 hours required, a maximum of 320 hours of non-patient care elective APPEs are allowed. So for us, this is a change because our hours they total 240. We can only allow a student 1 elective that's not patient-facing. So in the past few years, a lot of our students have enjoyed and tried to pursue careers in industry. And when we're able to do 2 electives in industry. With this new addition to this substandard here, they are allowed only 320 hours. So for us, allowing 1 240-hour elective in industry, for example, will mean that their other elective, because they have 6 APPEs, their other elective will be more patient-facing than industry. And so we have tried to be creative with this, and if somebody is very, very interested, may indeed allow a 7th APPE for that student if they so choose, in order to have 2 industry, for example, electives. So this one was something that a lot of people gave feedback on when the standard draft came out, trying to be the voice of the students and what they want in the careers they were choosing. ACPE maintains that they are preparing practice-ready, team-ready practitioners to deliver patient care with the PharmD degree. And 3.3, this subcategory, talks about preceptors. So for 3.3A, the college or school makes available and applies quality criteria for preceptor recruitment, orientation, performance, and evaluation. So part of the preceptor site evaluations that the students do at the end helps us to approve our preceptor criteria, that they're meeting all of our goals and qualified to be a preceptor. The majority of preceptors for any student should be licensed US pharmacists. So we certainly have an occasional one that is not precepted by a pharmacist, sometimes in management or something, but in general, most are, and that is part of our standard. And 3.3B, preceptor credentials and expertise. So all of our experiential courses in the curriculum are taught by individuals with the correct credentials and expertise necessary for their precepting responsibilities. And 3.3C, preceptor education and development. So our preceptors go through an orientation to our program, our mission, any specific learning activities and expectations that we have. We point out where the syllabus lives, and then the performance evaluation techniques before they accept students, so that they're doing an oral presentation, written presentations, etc. And then we try to foster the professional development of preceptors through a variety of learning tools, things like Lunch and Learn, our Preceptor Development Conference coming up on October 16th, and any number of other opportunities like mental health first aid that we offered. And so some of those core announcements are hoping and helping to increase professional development, as well as our CE impact. So we try to support preceptor education and development, certainly as a thank you for precepting and to meet the guidelines and the standards here. And then 3.3D, preceptor engagement. So our school is soliciting the active involvement of preceptors in the continuous quality improvement of our program, especially the experiential program. And so we do have a pharmacy advisory board, and it helps to guide us. We also use surveys. So ACPE will send out a survey to all preceptors. And then for another example, when ACPE visits our school, we also ask for volunteers to meet with them because they want a session with preceptors. They want to hear directly from preceptors about how the program is and how our students are out in the real world. So that's some of our preceptor engagement and some of our continuous quality improvement. There is room on the pharmacy advisory board. If anybody would like to join the pharmacy advisory board, please reach out. We meet both, it's a hybrid form often, so we meet both in person and on Zoom. And 3.3E is our student to preceptor ratio. Again, bolded is a change. So the student to precepting pharmacist ratio, this is going to helpfully allow for more individualized mentoring and targeted professional development of our learners. In most situations, student to preceptor ratios for IPE and APPE need to be 2 to 1 to not exceed that. So I think in most situations, we certainly are 2 to 1. If there was an exception, ACPE would just like to be able to hear why that might be if somebody has more than that 2 to 1 ratio. So in most situations, we're sticking to 2 to 1 or 1 to 1 for that student to preceptor ratio. And then for experiential learning, the last part I wanted to talk about today, 3.5C, and with the 3.5, this is experiential management. So it talks about personnel, so who's in the office, and then affiliation agreements, and also student employment. So students do not receive payment for participating in curricular pharmacy practice experiences like their IPE and APPE, nor are they placed in the specific practice area within a pharmacy practice site where they are currently employed. And so we have always tried to do this if a student is working in a hospital or health system, that they are placed with somebody in that setting that is not their direct supervisor or boss, and that they're not doing the same duties they are doing when they are receiving a paycheck for it. So they're doing some other things besides what they would be doing if they were working that day. Okay. So I'm just going to pause for a moment before I turn over to the second part about what makes an excellent preceptor. See if anyone has any questions on the standards as of right now. And we are, of course, always available for a phone call or a question or a Zoom if someone does have any questions on that, or are we meeting that, or any ideas for preceptor development that you'd like to see. We do have dedicated time to provide that. Okay, so I'll get started with what makes an excellent preceptor. And this is always an area of interest to see, well, what do the students think? And October 16th, when we have our preceptor development conference, we're going to have a student panel that they'll share experiences about great experiences they've had out in the, while they've been on rotation. So what makes an excellent preceptor? This is an article from AJPE, and in this study here, the student valued measurable teaching behaviors of award-winning pharmacy preceptors. The study used a thematic analysis of all student statements made about selected preceptors over the course of 5 years. The statements were made voluntarily in response to a prompt, comments about your preceptor. And the 21 preceptors selected were winners of the University of Washington School of Pharmacy Excellence in Clinical Teaching Award. And it's given annually to 1 or 2 individuals. They're nominated by students as exemplary preceptors. So after they asked this student prompt, some raters de-identified all of the information, and they tried to come up with themes that were apparent throughout. They came up with 17, these are short themes right here. They came up with 17 of them, and they further categorized them into 3 different groups that we'll see in just a minute. I know this is tiny to read, but I'm just going to highlight a couple things that students really thought what makes a great preceptor. And one of the first was, and this wasn't a behavior of a preceptor, so it kind of falls out of the theme in the next couple slides, but they were a great, amazing, excellent preceptor. So unfortunately, that doesn't show a behavior. It's just a comment. The second one was interested in student learning and success. So the preceptor really showed a genuine interest in that student's learning, in how successful they were and what they were understanding. The third one is they went out of their way and they always made time for students. So when that was evident, students really cited that as, contributing to excellency. And the fourth one is positive preceptor attitude. And the fifth one is answering and asking student questions and having discussions. So students really liked that their questions were answered. And there's another study after this, the same thing was teased out, that they really enjoy when they have their questions answered and student discussions. The preceptor was very knowledgeable. They were flexible, organized. They were accommodating to student learning and scheduling. I guess that's no surprise there that students enjoy them. They have a schedule and when they can have some modifications to it. The preceptor was also willing to provide a variety of experiences for the student, and they created a great working environment for the student. And often that was, we'll see it down below. They work well with their team. They work well with other healthcare professionals and colleagues. So they're modeling some of that behavior, and students appreciated that. They were able to teach students and they shared their own learning. They were clear in their expectations and they provided feedback. So students will always enjoy, no, they won't always enjoy. They like to have feedback. When it's actually not given, then that's when they really think the rotation wasn't as good as it could have been. They do really always come back to feedback. And sometimes, and we know this, students don't realize they're receiving feedback. So it is sometimes helpful to phrase that, I am giving you feedback, or we're having feedback Friday, or it's feedback lunch, so that they know they are receiving feedback. Also, they had enthusiasm and passion for patient care, and they worked well with others, and they advocated and had enthusiasm for the profession of pharmacy. So those are all contributory to making an excellent preceptor. The last one is they solicited inputs and suggestions from students. So the students liked being heard. But overall, one of the top things is they were interested in student learning and success. So this paper further broke down those 17 identified themes. They took out the one that didn't, they took out 2 that didn't show a behavior. And then they grouped them as role modeling behaviors, teaching and coaching behaviors, and facilitating behaviors. And they went ahead and put in here some role modeling behaviors. So that positive preceptor attitude, the preceptor was knowledgeable, and they didn't have to be knowledgeable in everything, but they showed expertise in their area they were working in. They had a passion for that patient care, and they worked well with their team, and they advocated for their profession. I know when you're with somebody who's enthusiastic about what they're doing, it's contagious, and students really enjoyed that and appreciated that. Another theme that they teased out, this teaching and coaching behavior. So interested in student learning and success. That preceptor goes out of their way or always makes time for students. They answer and ask students questions. They teach the students and they have clear expectations and the feedback. And then they were open to input and suggestions from students. So those are some of the teaching and coaching behaviors that were favorable to students. And for facilitating behaviors, they were flexible, organized, accommodating to student learning, willing to provide that variety of experiences. I know sometimes a student will ask to shadow pediatrics or have a different experience or be out maybe with a home health nurse, so that they are providing some different experiences if possible for the student. Creating a great working environment. So probably that setting where somebody feels it's okay to ask questions, it's okay to make a mistake, it's okay to talk through and work through problems. And then the student felt trusted with responsibilities, and they had some autonomy and some independence. This second paper, which is also from AJPE, or the American Journal of Pharmaceutical Education, also looked at the same type of things, factors associated with students' perception of preceptor excellence. So in this particular study, the object was to identify factors associated with preceptor excellence as rated by student pharmacists, and to assess the correlation of excellent ratings with things like the years that you've been a pharmacist, if you have any specialty certifications, and if you're a faculty or not a faculty member. So included in this analysis were 549 preceptors and over 2,600 student evaluations over the course of 3.5 years. So we'll take a look at what showed out on this one. So for the first part, where they're identifying factors associated with that preceptor excellence as rated by student pharmacists, the results showed themes such as serves as a role model, shows an interest in teaching, and relates to the student as an individual. Other factors that played into a preceptor being rated as excellence: the preceptor encouraged student participation in discussions and problem-solving exercises. They also like when a preceptor thinks out loud, so goes through how they're solving that particular problem. They're readily available to answer questions, and they give good direction and feedback. They also enjoy a well-organized practice experience, and when the preceptor is able to spend time with students. So that was the first part. So what makes a preceptor excellence in this particular cohort of students? And then the second part, so what correlates with excellent ratings as far as how long you've been a pharmacist, if you have any specialty certifications, or if you are a faculty appointment or not. And the darker box of the darker gray, it's a good, fair, or poor rating. And the lighter one is an excellent rating more than 80% of the time. And interestingly enough, there was no significant difference between appointment status. So it didn't matter if somebody was adjunct faculty, so they didn't work for the institution, or whether they were, practice or tenure track faculty members. With respect to the correlation between years as a pharmacist and an excellent rating, 33% of preceptors who were rated as excellent had an average of 14 plus or minus 12 years in practice, whereas the 67% who were rated as good or poor also had 14.9 years in practice, give or take 12 years. So interestingly, it didn't matter for your rating how long you've actually been a pharmacist. And then there was no difference in the ratings of preceptors with and without board pharmacy certified BPS certification, or in the ratings of preceptors with various terminal degrees. So it gets back to that part, I think, about showing an interest in the student's learning, being available to the student, asking questions, giving some autonomy, giving feedback, serving as a role model. I think those things really resonate with students and make the experience a good experience, make that preceptor and student relationship really strong. So as a takeaway today, we talked about the standards, clarifying the intent of programs, how we have the ACPE needs to meet USDE requirements, so the United States Department of Education requirements, in order to be the accrediting body. How the standards 2025 are creating direct patient care pharmacists, and part of that is why they have limited some of the electives and what a student can do. It needs to be patient facing most of the time, or providing patient care. They also want 100% of graduates to sit for NAPLEX. So over the last few years, we've seen it change, and where a couple years ago, 8% did not sit for NAPLEX. The most recent data shows 13% not sitting for NAPLEX. And the standards 2025 and ACPE would like to see all graduates sit for the NAPLEX. And that goes along with their theme of creating, with this degree, direct patient care pharmacists. And the last part of our presentation today talked about what makes a preceptor great. And hopefully some of those things resonate with you and you can take away maybe some new ideas or just understand some of the reasoning behind some of these standards and what we do. So I'm happy to answer any questions. I know we're just right about at time. I'm going to stop sharing my screen and thank you all for coming. This will be recorded for those who did not get to come to Lunch and Learn. They can watch it later at their convenience. All right. Well, thank you very much for precepting and for being present today. And we'll see you all out there.